We're welcoming Christina Ware this morning from Occupational Rehabilitation. She's going to be talking about low vision and some of the things that we need to be prepared for and know what to do with. So Christina, welcome.
Thank you. Good morning. So again, I'm Christina from Occupational Therapy, and I work primarily in GR and inpatient, and then sometimes in outpatient therapy, and see quite a few residents with low vision who have complaints of not being able to read. Mostly is one of the main complaints. And in this population, we see a lot of residents with macular degeneration, which is a loss of your central vision, and that makes it very difficult to read or to even move around and being able to move around in your environment. Another very typical visual deficit that we see in this population is also diabetic retinopathy. Oh, really? Which is mostly just fragments of vision are lost all throughout. So again, you kind of see little patches and little puzzles. So that also makes it difficult to do anything really in your daily life. Another very common one you're familiar with probably is glaucoma. Which of course takes away more the peripheral vision, so you're kind of seeing through like a little tunnel. Again, that makes it difficult, not so much to read, that's a little bit easier to manage that, but mostly to get around in your environment. And then of course cataracts, which everybody is very unfortunately familiar with. That's a little bit more, not as debilitating as the others because they can do surgeries, and so typically people do pretty well with that. But in occupational therapy, we look at just your everyday activities on being able to get around in your apartment, in your environment, being able to do your daily activities and take care of your basic needs and higher level needs as you age, including any leisure activities, in being involved in the community. And when people have low vision difficulties, that can really impact what they're not able to do anymore. And unfortunately, a lot of people just revert to their apartments and they stop doing their activities that they used to really enjoy. That's where we come in. Once the residents have gone to their eye doctors and they got their confirmation of terrible, unfortunately, eye diseases and what they're dealing with, they can be referred to occupational therapy. And what we do is we come, usually, I tend to come into the residents' apartments only because that is the environment that they need to be functioning in. That's where I do a home assessment. We just kind of look at the what visual deficits they're dealing with. The residents are usually very good at explaining what they can or cannot see because it's difficult for me to...
where the frustration comes in.
Exactly. So we just really kind of narrow down what their abilities are and then what their goals are, what it is that they were able to do before, but now because of the visual difficulties or deficits, they're not able to. So then in the home, we can make sometimes modifications just in the environment, really. A lot of times lighting may help some of the residents with some of the eye diseases. Some people prefer bright lights, depending on what eye difficulties they're having. Some people really cannot deal with the bright light, so they need a little bit more shaded lighting. In the home, typically the residents are able to tell me what they're having difficulties with. Most of the time, it's managing the appliances. They can't really see the small prints. They can't read their medication labels, which otherwise they would be able to do. They can't, sometimes even the faucet, you know, the hot and cold, if they can't even locate it sometimes because of the severity of their visual deficits. So just even taking a shower, just even getting a cup of coffee might be difficult for them. So we kind of, and everybody's so different, so individual.
Yes, each person has their own frustrations to work out.
Exactly, and even though they may have the same diagnosis, let's say macular degeneration, different lifestyle, and also different degrees of how much their eyes have progressed over the years. So in the environment, I can help them with lighting. Changing the lighting sometimes really helps. For instance, a lot of people really enjoy reading the paper or just doing any, some of the ladies really like to do knitting, crocheting, or any other activities. Right. Playing cards is very, you know, popular. And so if you just change the lighting, sometimes, just some people prefer the brighter lights or the cooler lights. Mm-hmm. Some people like the lighter tones or the warmer tones. Mm-hmm. So I have a couple of light bulbs that we can kind of try out, and then placing that I take to their apartment, and then placement of the lighting as well makes a big difference. Sometimes if somebody really is having a hard time seeing anything small like the appliances to be able to set it, we can do little raised or different bright colored little dots that we can put on their appliances, and they can help feel for it, so they know where the label where they need to set the whatever appliance they're using. We can use colored tape that might help them a little bit in terms of going over like a threshold, or if they need to locate some things in the bathroom, or some people have a difficulty with just seeing the edge of the table or the edge of the counter, so they misplace items for that reason. So we can work with all of those. And I really enjoy working in their environment, so that we can get them started there. And if they are involved in an activity that outside of their apartments, they have card games that they go to, or having difficulty in the dining room with the menus or something like that, then we can also go over and then just kind of problem solve that and help them. A lot of residents, unfortunately, wish that once they get the diagnosis, let's say the macular degeneration, which is unfortunately not a curable disease, they just kind of hope that I'll give them a magnifying glass and that'll solve it all. And I wish it was like that, but it is not. We do have a wide range of magnifying glasses with different magnifications, different styles, different shapes, some with lights, some without, that I can also bring to the residents and they can trial it. Again, they're so individualized that for some people it works well, some people it does not. But there are different techniques that they might be able to learn to compensate for their lower loss of vision. Because really the ultimate goal is to be able to get them back to enjoy what they used to enjoy, activities they used to enjoy doing.
I always appreciate those that I see around with the low vision who continue as much of their normal life as they can. There's some, you know, you'll pass in the hallway and you'll speak to them and they sort of close in because they don't know who you are.
And some, like with the macular degeneration especially, because of the loss of your central vision, a lot of people look at you and they can't see your face. They see around you but not your face. So there are some techniques that some people are able to learn. It's very difficult, but some people are able to learn to use their peripheral vision for that reason and still be able to make out your face and recognize you and not feel bad about not noticing you.
I think those of us who greet people like that, though, need to remember that maybe we should say, you know, it's so-and-so, you know, how are you today?
Introduce yourself, And I think I do encourage my patients also, the residents that I see and work with for low vision, is to not to be afraid to just say it. When
Who are you?
Yes, when they meet somebody and just say, I don't have good vision, I'm not able to see your face, can you introduce yourself? Or, you know, just as a, because if you don't communicate that, then the other party doesn't know either, so it just makes it a little bit more easier.
Okay, sounds like there's a lot available.
There's a lot available, so the way the residents would be able to access this service, if they have a need for it, is they would see that any physician can really prescribe occupational therapy. What I would do recommend, though, if somebody is experiencing, of course, difficulties with their vision, is do see the ophthalmologist and get their eye health taken care of. And then once they've done that, then they can come to me or come to the occupational outpatient department, and then we can work with them on making life a little bit easier.
Yes. Now, I noticed you had a little chart there of some of those buttons.
Oh, the buttons, yes. These were the little buttons that I was talking about earlier. It's if somebody's having a difficulty with seeing the appliance markers or finding the light switch or something like that, then we can put these little raised bumps. There's different sizes, different colors, different shapes. And so what I would do is I would check with the residents which one they can feel easier, or if any of them they can see if the contrast of the color is a little bit better for them, then we can choose that little button and then we can just mark it on the appliances. I tend not to do too many, of course, because if you mark, let's say, for instance, on the washing machine, we just tend to do either on or off or hot and cold, just a couple, so that the resident doesn't get confused. If there's too many bumps, then you don't know which one is which.
You don't remember which one was which.
But they're all different shapes and different sizes, and some people do better with certain sizes, certain shapes. Some people are able to see the colors, and the color contrast is a little bit better, so we kind of play with that. And usually it's a very successful, quick little solution for everybody.
Right, right. I know I was mentioning earlier that I do Braille, and sometimes I have taken the that material that you do, the plastic that you cover things with, and put Braille on it, and then they can stick that on something if they know the basic Braille.
Wonderful, yes. Yeah,
lettering.
Then they're able to figure. That's wonderful.
Right.
Good idea.
That works too. So thank you so much, Christine.
You are very welcome. Thank you for inviting me.
And I hope any of you who have some low vision problems will take advantage of this, because you don't have to withdraw from society just because you can't see well.
That's right.
Just remember that.
Thank you very much.
You're welcome. Thank you very much. We're going to look at a film that was made about the Diversity Day that was here recently, and I understand was a big success. So let's see that tape right now.